Hello, hello.
Hey, I'm Michelle.
I'm Julia, and welcome to
Just getting
Getting Better
better.
Live Edition, people. We're
Live
back
edition.
another
Yes.
week. How you doing? How you doing?
I'm good. Thank you, everyone, for joining us. We are here live with you tonight. We're excited to have one of season one's favorite guests,
Yes.
Dr. Kamilia Smith. She's going to be joining us in a few minutes. And while we're preparing to sitting in between the launch of season one, which is all out and available on Apple and Spotify and through our website and YouTube. You can all watch and listen. We are doing a couple lives this month as we're preparing for season two, which should launch in at the end of September. So,
Hey, babe.
Julia,
Yes,
how are you?
I am good. I'm actually, it's hot as all get out down here, in the South. I mean, it is that
Yes.
August oppressive heat, but I'm good. I got my Topo Chico as
Topo
always.
Chico.
Always beverage of choice.
Do you have anything else?
Of course I do. I just was again in the Willamette Valley. So I
You went with the Topo Chico, so I wasn't sure.
I probably, I have O'Bain 2021 Ananata Vineyard, EOL at Amity Hills, Oregon, Pinot Noir, made by Isabel Mounier.
Oh, I love Isabel Mounier.
Yeah, Isabel Mounier,
Great.
History of Evening Land.
Yes.
So excited. Finally got to tour the vineyard there in Eola Amity with Andy Lytle from O'Bain. So it was really nice. It was really nice.
What a treat. I haven't seen Isabel in, gosh, it's probably been like 5 years. Yeah, she's great. I love her. I love her wines. So I opened up a special treat tonight because, as you said, it's bloody hell hot.
Yes.
I am drinking so to know me is to know how much I love Riesling. And I love Riesling from a lot of places, but I love it from Alsace a lot. So I am drinking this 2015 Francois Bear that I was able to visit them in 2018 on a trip. Yes. So it is a Grand Cru from Clos de la You know how I am pronouncing French.
Yes, I know. It's okay.
Trell? Is it Trell? Clos de la...
Yeah, just hold it up a little straight for me. Yeah, Clos de la Terrell.
There you go.
There we go,
people.
Yes.
But it is fabulous, fabulous wine. So at any point during our conversation, if I happen to kind of... it's either because I'm having a hot flash or I'm falling in love again with the sip of the wine.
That is both. Two things can be true. Two things that can be a hot flash because I'm a one red now maximum. She was kind of pushing it for me, depending on the day. Yes. And so yes, but I'm still in the spirit of the Willamette Valley, a favorite place of ours. Yes. I mean, we got. You know what? We got to take this podcast on the road, and that in Oregon would be one of the places that we definitely take it on the road.
Are you kidding me? It's a place in my heart. I have a whole place in my heart
right here.
It's called Willamette Valley.
Yeah, and so I'm still on the high from it. So I'm just drinking a beautiful wine made by somebody who we both admire, respect in the industry. So yes.
Okay.
Awesome. Are you ready?
I am ready. I'm like I said, I don't know if if I'm having hot flashes or if it's just because it's 105 degrees every day.
And the third thing is because you're excited about Dr. Kamilia coming on to Just Getting Better podcast.
I am.
So that's the version. So that's what her again, as we move into the new season and keep on going and growing as people. That's the one beauty of it as well. But I think it's just time to bring Dr. Kamilia on because
I think so too.
She's amazing. We got a lot to talk about the big M word.
Backed by popular demand.
Popular demand, Dr. Kamilia.
Yes, season one. And oh my gosh, the questions and comments and just ongoing conversations. I literally had someone text me this morning about something like for you. Like it's just constantly, it's always about you. So how are you?
I'm wonderful. I'm also hot down here.
Yes, you are.
In
You and I
Texas.
both are in Dallas.
Mhm.
Hey, Jim
Hey,
Morris
Jim.
is here.
And I'm in Louisiana, so it's just brutally hot. The heat degree, it's just you walk out, you sticky, you're burning. It is the summer in the South. That's the only way to describe it.
Absolutely. Absolutely. Yeah. So give people just a brief.
What, Dr. Kamilia? Cheers.
Oh, cheers.
Cheers.
Yes. Oh, you've got wine too.
Yes, yes, wine.
White in Texas because it's
Yeah.
hot.
What are you sipping tonight?
A&R. I don't know if you know of A&R.
Mm-hmm.
It's one of our favorites. My husband, if he sees this, he's going to be like, he's at the hospital right now working. He's like, oh wait, she opened a bottle of A&R. I did.
Yeah, it's one of those. It's one of those Tuesdays you needed to.
Special times call for special measures. Yes,
Absolutely. Yes. 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 So, cheers. Cheers. That's all. Yes.
So, we've talked to you before on the pod, and we're here. And one of the things that I think all my friends are talking about, I'm reading about, it's on my radar. I'm at that age. We're all at that age in conversation to a lot of my friends. And I'm also talking, because I learned from you, to talk to my nieces who are younger than me, the generation previously, to tell them about the big M word, which is menopause. I mean, in all things, whole, woman's wholeness, not just that part of our life, but just, the season that I'm currently in, and a lot of my friends are currently in, and that actually you specialize in.
Correct. And, it's never real till it's happening to you. And here I am. So I think that's special. And it does. I think that it is a buzzword right now. Isn't that silly? I mean, it's kind of silly to think that we waited this long to be talking about women's health. But it is a big buzzword. And with that comes a lot of hype and attention, which is really great. And making women a priority in the industry is amazing. And so, I think we're going to be in for a really fun ride. I don't see the hype going away anytime soon. I think we're just gaining a lot of momentum. And within that, that's a big call for providers to really do their legwork. And I have been sort of digging into it for the last 5 years. I am by no means an expert. I'm just one that started about 5 years ago and said, hey, there's got to be more to medicine for women. We have to be offering them more. It was just a constant nag for me in my practice. And it's funny because a lot of my friends, this is what I think is real funny, is a lot of my friends, peers, when I left obstetrics, thought, she's tired. She doesn't want to deliver babies anymore. I was tired. We're all tired. And while that might have been a little bit true, I also had a nagging just like, hey, there's more to healthcare for women. There has to be, because people are leaving my office with unanswered questions. I don't have the knowledge. They don't have any solutions, and they're going to go back to their day-to-day life. And truly for me, it was not something that I was willing to accept. And so it was a calling to say, hey, there's got to be more. And when I really started just looking beneath the surface and looking for resources, I easily found them. And again, I am new to this. I think 5 years new. I am not near as new as some people who just jumped online about 6 months ago. And a lot of these individuals are very smart. They're very curious. They're quick to obtain information. I'm talking about consumers, and I'm talking about women as patients and also as practitioners. But there are people who go before me who have really laid the foundation for us. And I think it's really interesting because I think that there are social media doctors, and then there's doctors on social media. And I fall in the latter group because when I get done at the end of the day of seeing patients and still haven't even started charting, I have a really hard time looking for some inspiration to get online and just talk to the camera. It's not something that I just can, find the bandwidth for oftentimes, because I still have a lot of loose ends I have to tie up with patient care. So I think you've got doctors that are on social media who are credible, but they're not really having a lot of face time. And then you've got social media doctors. And so what I hope will be is that we can all sort of agree on the right approach for women. And those that aren't necessarily seeing women all day long will have a level of empathy for some of the side effects and things that women are being offered online, how they really play out at the bedside. And I've always been a big believer, like, people make decisions, especially, people make decisions. I worked in DC in 97 and I worked in the state level legislature in 98. And what really called me to women's health was I was like, we have people making decisions and they really don't know how they trickle down to the bedside. Right. And so that's like, forget about any specific reproductive rights, all things said, like how hospitals make their decisions and just how things are, made, and really you don't see how they trickle down to the bedside. So I think that we're going to see a lot of that, and you're going to see physicians like myself who are maybe going to say something different when we sit down one-on-one with a woman, and really guide her through a personalized journey and a care path that's unique to her, as it should be, based on her personal history, her family history, and just, wanting to increase her lifespan, reduce her quality of life issues, and spur her on. And we may not present it just like you see in a social media story. So
I think for women's healthcare, I think now, because, I always say social media is a blessing and a curse. I do think women are having conversations about their healthcare that previously in my 20s and 30s, I wasn't having, right? So now I'm having these conversations, and I'm also, as a person who I don't have children, but I have nieces who also have children and some don't. I'm just getting them on their healthcare journey outside of just blood pressure and, the basic physical things that you get for your test pass, not just cholesterol, but them as a whole being. Because so long to me, a lot of healthcare is, well, if you don't have this, then you're okay. And if you don't have this, then you're okay. But if you have this, then we focus on this. And one thing about you focus on the whole person in healthcare, not just some of a part of healthcare.
And when I hear you say that, I feel like, well, that's a weird thing to say, because doesn't everybody practice that way? And I always go back to, I only know what I do in my office. But what I think I'm hearing you say, Julia, is that we treat a diagnosis, and that is how we are trained. And I will tell you, things are rapidly evolving for women in healthcare. But a couple of things still have to happen, right? So like you just alluded to, we have to be okay as women with saying, I need this to treat blank, right? And whenever on a weekend, if I get a message from the patient, the first thing she says is, I'm so sorry to bother you. And I think, why are we apologizing for needing somebody to address a healthcare concern? So first,
women apologize a lot. So
I'm thinking you're getting a message on the weekend, like
but then they're apologizing, and I'm like, why are you apologizing for advocating for yourself? Right? So first of all, we have to stop that, right? And there's been a lot of rumbling on social media about, I use the IUD as an example. Like, why the heck are we just not giving women pain? Listen, I got my IUD replaced 3 weeks ago, and I was like, I am about to punch my friend doing it because this is terrible. And I was like, where's my side attack? Where's my this? She's like, you'll be fine. And she's right. I was. But the reality is, like, why are we just now offering women like pain relief for a procedure in the office?
Yeah.
And so we have come a long way. We got a long way to go. But the first thing that has to happen is women have to be okay. And you know what women will do? They will do anything for their children. They'll do anything for their kids. So I was like, you know what? Another way to get these women to come into my office is to say, all right, well, then prioritize your daughter. And I'm going to create a relationship with your daughter so that she understands how to converse. I did a consult today with a young girl, a 15-year-old, and her mom's like, I just want her to have a healthcare home. And I was like, all right, you're going to text me with your next cycle. You're going to tell me what your first couple of days are like, and if they're bad, and you will talk between classes or whatever. And we're starting that conversation with a young girl about, this was happening in my body. Because neither of us could figure out why she was there. We're like, there's got to be a reason your mom brought you in. And here I am trying to treat a diagnosis. I fell into the same trap that I'm trying to get rid of. I'm like, there's got to be a reason your mom brought you in. And she's like, I want her to have a healthcare home. I want her to have a relationship with a practitioner. And I want her to get comfortable talking about what she needs outside of me. So we, as grown women, have to do the same thing. And I don't think any of us are there. I just don't. I didn't ask for pain medicine that day. I was like, oh, okay, I can do this. So that's what has to happen, number one. Number two, we have to get information, reliable information, good information. And it can't be handed down from the old, the old skeletons in the closet that have been making I mean, no offense, but it can't be handed down for people that it's like, well, this is the way it's always been, and this is the way it always will be.
Mhm.
And our FDA is included in that. They just are obstinate about entertaining the notion of things for women. And so that has to change too. So we've got a lot of work to do. We're doing a lot of work. And I think a lot of these, and I'll go back to these social media doctors, that is something that they do well. They are loud and unapologetic and knocking on the door and asking for more for these women in a way that I don't have a platform to do. So for that, I am very appreciative of that.
Yeah. But how do women, so we get so much information from social media doctors. I mean, there was a point in time, as we talked about, for hundreds of years where menopause was never discussed, never talked about. Now, for some reason, it seems to be in vogue and it's being talked about abundantly, which in some ways is good. There's lots of good books, there's lots of good content, lots of good articles, good guidance. But with a massive information also comes a massive misinformation. And if you're just a woman, you know, like you just said, women don't always, you know, go to their doctors more than like once a year, unless there's a problem, looking for a diagnosis and stuff. But we see things on social media, or our friends see things and then they tell us, and then we have these conversations. How, Dr. Smith, do we sift through all of this and know what's real information and what's not real information?
Okay. So, Dr. Kamilia, I know you kind of briefly spoke on it, but can you go a little more depth into what is a social media doctor? Because our audience is asking the question and kind of like explain just a little bit of what you mean by that.
So I think to me, a social media doctor is somebody who practices medicine online, right? They are speaking to their audience and they always caveat, this is not medical advice. But when you have somebody that is vulnerable and looking for information, and you're speaking to their pain points and you're telling them, hey, we've got data to support blank, 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 blank. They don't know what that data looks like. They don't know the difference between a relative risk of something and an absolute risk. And they're just saying, hey, this is what you should be doing. And I would say more of that, it would be a social media doctor might be somebody who has made their career educating at large. And I think that's a big difference in somebody who is a doctor who sometimes gets on social media, who just wants to advocate for women, deliver information, reliable information, but it's not our vocation. And so I think it may actually become a tale of two cities in different vocations even.
But I think too, because, you know, we all self-diagnose. I mean, come on, I'm sure you had a patient like come in.
I self-diagnose myself all the time. I know I do. And I talk myself off the ledge.
Yeah.
And then I say, what, you know, and then I try to move on.
But if we go to a friend and say, you know, oh, I'm dealing with this issue, and then the friend's like, oh, well, I read this thing and let me tell you about it. And it happens to come from a, you know, by your definition, a social media doctor. And I don't know that it does. It sounds good. Like, how do we know? How do we sift through all of this? It's so crazy.
It is crazy. But you know, what's great is I love it when patients come in and they say, I've listened to so-and-so and so-and-so, and I try to keep up with it as much as I can. And I love that they open the floor for discussion, and then we're actually having like a collaborative appointment. I find that far more fulfilling and challenging to me and pushing me than if they just came in with a blank slate and didn't know anything. So I love that my patients go online and get information. I just want to always let them know, hey, listen, but what I'm going to tell you is going to be individualized to you based on these things. And of course, it's my lens, right? They're getting information through me. So I always think, and there's never anything wrong with getting multiple opinions about something. It's just, you know, to the point if you let it confuse yourself. And so, you know, I think that women are coming in and they've consumed a lot of information when they sit down with me, and they're really sharp. Now, what I always tell patients is nothing is all bad and nothing is all good that comes in a bottle. It's just not, because we can treat menopausal symptoms. We can risk reduce for certain comorbidities, the word I like to use, which means other things that happen to you along the way while you're aging. We can risk reduce those. We can, you know, understand your own personal cancer risk based on lifestyle and family history. But what we can't do is really ignore the fact that medicine, prescriptions, supplements are just one, they're just one spoke of the wheel, right?
Mm-hmm.
And so we have to, like, if your sleep is no good, it doesn't matter.
Mm.
Glad you're on hormones, glad you're on testosterone. If your sleep is still like stinks, we're probably way behind the 8 ball still.
Okay, what do you mean stinks? Can you just go into like that about sleep? And I say this as a person who was clinically diagnosed with insomnia in my 20s, who had to create a sleep routine like we do for kids, like take a warm bath, read a book, get out. You know, it's more than the blue light for me. It's a lot of factors. So when you say that, like about the sleep, we know it's important, but what do women need between a certain age of sleep? What do we need to do to look out for, and what do we need to do about our sleep?
Well, I think one of the biggest barriers to sleep that I see in a day-to-day in a woman, a lot of it is anxiety. So if mood is unstable, we need to stabilize that, right? And so if you wake up 3 a.m., mind racing, list going off in your head, or just that sense of panic that we wake up in when we have a senior in high school, I don't know, just saying. When you wake up in the middle of the night and you're thinking, did I sign up for that parking pass or whatever it is, we have to be honest about that. So I think anxiety is a big issue. And I think that depression, I think people who are, they lack motivation because of a low mood. They're less likely to move around during the day. They're less likely to go to sleep and hit all the appropriate sleep cycles. Like my daughter said this morning, she's like, she's 11. She's like, I think I need melatonin. And I said, why? And she goes, it took me 20 minutes to get to the good stuff last night. And I'm like, well, how long is it taking you to get to the good stuff in your sleep, right? And I was like, well, melatonin doesn't get you to the good stuff. Sometimes it skips over the good stuff and just gets you to sleep. Yeah. So I really like to talk to patients about sleep. And, I kind of sit back to some of this, like these tracking monitors, but I really think there's a lot of benefit to us seeing data. And I encourage a lot of my patients to really find something that is good. I think the Whoop is probably pretty good right now for sleep data. And I just sort of sit back, but I'm a big proponent on sleep. And a lot of times treating vasomotor symptoms, hot flashes, night sweats, if you're not treating those, the sleep is really disrupted. And that has a lot of cardiovascular implications. Heart rate goes up in the middle of the night during a night sweat, and you'll get runs of what we call tachycardia. So I like to look at heart rate. I like to look at heart rate variability. I like to look at sleep data, how deep you're getting. And if I can work with a woman around that, I sometimes will tinker hormones around that.
Oh, wow.
To see and looking at that data. Now that's all new for me. Listen, I am learning as I go. Is anything I said right there evidence-based? No, but if I could get a woman to sleep well, I know that's been true.
Me and my Aura ring, thank you.
Yes. Whatever it is that's for you.
I don't even know what that is.
Now, if a woman I've had women come in and say, I feel so good, but my Aura ring says I'm not sleeping well. I'm like, we're going to go with how you feel.
Yeah.
Okay. We're going to go with the fact that you are feeling better than you've ever felt. And we've made these adjustments and you're sleeping well. So I don't know that it's always the most reliable, but I do think sleep is important. And I think we are, sometimes we will not treat vasomotor symptoms in women because they're not necessarily bothersome to them. But when I can see them wake up and I'm like, hey, when you wake up, I want you to know what time you had that hot flash or night sweat in the middle of the night and you're kicking off the covers and taking the clothes off and turning the fan on or whatever it is you're doing. I want you to note that time. And then I look back and I look at their Apple Watch and their heart rate has gone 20, 30 beats above what they were at rest before that. So we do see those things. And so I think that there's a lot of benefit. And I think we're going to see a lot more coming. In fact, I have seen more coming out on sleep. And a lot of these medications that are treating vasomotor symptoms, they've got sleep data on them. And that's really new. That's in the last 6 months. So stay tuned for more on that.
Oh, good.
I received a question today and it fits right into this conversation. And I had never heard of this before about black cohosh.
Black cohosh.
Cohosh. Okay. Yes. And how it works for night sweats. and it's an herb or something. Yes.
So there is a wonderful position statement by the Menopause Society. And I will tell you, I do not treat everything by the Bible, right? Like, but there's a nice position statement by the Menopause Society that came out 2 years ago for non-hormonal treatments, non-hormonal modalities for the treatments of what we call VMS or vasomotor symptoms, which includes hot flashes and night sweats due to menopause. I caveat that with, you can have hot flashes, VMS, night sweats due to other things that are not necessarily due to menopause. So, but as it pertains to VMS due to menopause, position statement was done, and they actually looked at and gave us recommendations on the dosing. This is for non-hormonal treatments. And to date, there are only 2 FDA-approved non-hormonal treatments for VMS. Black cohosh is not one of them. Now, is it because that somebody at the FDA has an issue against black cohosh? No, we just can't see when you look at the studies, and there are lots of studies, when you look at the study, well, I say lots. There's lots of people saying that there's good information about it. But when you look at a couple of studies, you look at the reduction of vasomotor symptoms compared to placebo, there's really no significant increase.
Okay.
Am I telling you not to take it? No. Is there placebo with everything? Probably. It doesn't matter how you get there if you feel better on it. But I think we have to be honest with patients. And so when this ad pops across with somebody beautiful and thin and has been on the red carpet and it's now said, this is your menopause supplement, and the back of it, the main ingredient's black cohosh, and you're sending $49.98 a month to whoever for that bottle, that's when I begin to have a problem with it. Cause I'm like, hey, we don't have anything to support that. Will I tell somebody not to take it? No, I will say, hey, listen, let me give you something that really works. But we do have a couple of medications that are FDA approved. But I will tell you, there are other medications that aren't necessarily FDA approved. Doesn't mean they're bad. It just means they might not have the same relief, and they might come with more side effects, and they might be a little bit of a, when I say dirty drug, doesn't mean bad. Dirty drug means it hits a bunch of different receptors that I don't want it to hit. I want it to hit one receptor. I want to be more directed to a certain receptor. So I don't get constipation. I don't get dry mouth. I don't get daytime sleepiness, those kind of things. So like gabapentin, oxybutynin, those are great drugs in breast cancer survivors who maybe can't be on hormones. But now we've got some other drugs that you can take that have actually shown a significant reduction in not only the severity, but the frequency in which these symptoms occur, especially at night as it pertains to night sweats and during the daytime. And one of my friends today, listen, I have some really smart friends. Y'all don't know this about me, but I have really, really smart friends. And what do they say? You're known by the sum total of the company.
Yes.
I got me some real smart friends who've been doing menopause longer than I could say the word. And so one of my girlfriends today, I was like, listen, I'm actually having hot flashes. And she goes, isn't it weird? Don't you feel like everyone is just staring at you when it happens and they can tell? And you're like, oh my God, you feel like you're turning beet red, and you look in the mirror and you're like, nope, still pale. And but you feel like you're like, and my kids love to come over and be like, oh, she's having one. And they like to touch me. And then the whole thing, the whole skin ecosystem changes. Anyway, it's just
like, get your damn hands off me. What are you doing?
No, I mean, like, if you're going to spend your life trying to take care of women, then you got to be honest about the things you're having yourself. Right.
Sure.
I love that.
So, and it's not, I haven't found it fun yet. I don't know.
No. One of the guests that we had on season 1, Christine Dierkla, who's a Peloton instructor.
Oh,
Yeah. She has introduced in her class the hot and cold crew. So I'm like, yes, I'm a member now of the hot and cold crew.
I mean, yeah, but you know what? It's all okay. I just tend to focus on the fact that we have to not shove our symptoms under the rug, because, if you look at the statistics, especially from the SWAN study, the big longitudinal study of women across the lifetime, if you look at that and you see the amount of women that have hot flashes, 7.5 years on average duration, more than 50% say that they're moderate to severe. But if you look at the data showing up in my old practice, there were not 50% of my menopausal patients were not complaining of them. And so we have to stop. Just like, I can still ask women, like, do you have issues with incontinence? They're like, oh, no. I'm like, okay, well, do you leak urine? They're like, oh yeah, but it's not a big deal. I mean, would you leak urine when you're on a run? Yeah. But I just know I have to empty before I go, have to empty when I get home. Sometimes I have to wear a pad when I run. And I'm thinking, well, it's along the same lines. Like we will eventually get to the point where women are okay with saying, hey, I make an appointment just for myself today to talk about my bladder. Not just happen to mention it if she extracts it out of me when I waited a year to come in for my annual. And so I think that needs to be the next paradigm shift is, women are going to have to just be okay with that. Now, I think they will if they feel like they have an ear that wants to listen and that will be able to offer them some solutions and be educated to that end.
Okay, we have a question on Ozempic, semaglutides. What should women know about them since they seem to be continually evolving all the time?
They're very smart drugs. They're very good drugs. A little back history, GLP-1s. Ozempic was the first drug. The compound is semaglutide. It was studied in diabetics, and they lost weight, and it was profound. Now, that's not always the case. You can do good glycemic control in a diabetic, and it does not result in weight loss. But weight loss, as we know, drives down insulin resistance, and over time improves their long-term survival and their blood sugars. So they were like, well, oh gosh, maybe we should just study it for weight loss. So they studied semaglutide for weight loss. That was Wegovy. So Ozempic and Wegovy are the same thing. They're dosed a little bit differently. You can get more money if you have two drugs that work really well in two different populations, right? I mean, you don't want just one drug. You want Ozempic for diabetics and you want Wegovy for weight loss. And so it's a beautiful drug. Are there side effects? Yeah, but do you know the side effects? Do any of y'all remember the side effects of those original weight loss medications that were like Orlistat? Like they were like, you may have like fecal incontinence, you might lose stool, your stool's gonna look basically like bubbles. I mean, it was just fine for a woman to like chart her drawers and as long as she was skinny. And so I'm like, when I hear people say, oh no, but the side effects, I'm like, do you know the drugs we used to give people to get weight off? And none of them had any really good long-term results. Like as soon as you took somebody off of them where they plateaued at 24 months and that was it. And the same thing with intermittent fasting. The data on that is you got to be pretty perfect at it to get long-term results. And at 24 months, you sort of plateau. And then the minute you come off of it, you return to your weight. And the body has a nice little set point that's actually not very nice, but it does a really not nice thing and it resets on you. And so the GLP-1s with semaglutide, I mean, they're just wonderful drugs. And then you've got tirzepatide, and that is Mounjaro. And Mounjaro, you think of Mounjaro just like you think of Ozempic, studied for diabetics, profound weight loss. So then we said, hey, let's do Zepbound and Wegovy being very like the weight loss component of these two very, so you got semaglutide and you've got tirzepatide. So those are great, great drugs. Just like anything else in the world, if they get in the wrong hands, it's not good. And I live in a city of thin. And
I think we live in a world of thin. I think it's a world of thin. I don't think it's just a city. I think it's a world of thin.
It just upped the ante for people. It was like it was hard enough. And now we've shot past. And so, and I harp on my patients, like, listen, if you want this medication, here's my cutoff point. I have an in-body scale. I do not charge them to use it because I require them to do it. So therefore I cannot charge them to use it. And I look at their skeletal muscle mass. I'm looking at all the things, and then I'll get a full out bone scan on them. If they're teetering too low and they've got another risk factor. So we have to be careful because these drugs, yes, thin is in as it always was, I guess. But just like anything, if they get in the wrong hands, it can be somewhat of a disaster. And so you can go on any online platform and get compounded, and compounded is not generic. So there's a difference. And I do think that the shortage is going to come to an end. And I think there's going to be a cease and desist on these compounding medications for them. But what I am really leery of compounded medications. But if I have a woman who's morbidly obese who I think is going to die of a heart attack, and that is the only thing she can get, I will give long pause to that and say, okay, everything is risk versus benefits. And it's not like I do not support widespread use of these medications, but I do think sometimes we've got to get weight off for patients. And We used to do that with the Atkins diet. We're like, dip your bacon in queso so you can lose weight before your open heart surgery. I mean, is that good medicine? Get your pork skins because you're going to lose weight if you only eat pork skins, and then you'll be a surgical candidate for your bypass.
Yeah.
I don't think that's really good medicine either. So, so anyway, I don't know.
Okay.
Interesting. Yeah.
Yeah. Because we had another question that said, does weight gain play a factor in increasing the occurrences of perimenopausal symptoms?
It's a very good question. Whoever is in the audience that asked that, I think they might know the answer because they're super smart. So women who are obese, so I always tell my patients, if you have conversion of hormones into estrogen in your adipose tissue. So more real estate, more conversion, more estrogen. And estrogen is something that thickens the lining of the uterus. So if you look at a woman and she has a lot of adipose tissue, a lot of more real estate for peripheral conversion into estrone and estrogen derivatives, she's going to have a very, very thick endometrium, and she's going to bleed a lot, heavy periods. So women who are obese, they actually have more severe hot flashes premenopausal, which is kind of not, necessarily cool. But if you have a woman that's super thin, she lacks adipose tissue, she lacks estrogen and more endogenous production, she can have a little bit more hot flashes as well. So I do think it plays into it. There was a great little paper that came out, and it was all retrospective. And it was like, hey, let's look at all the women that were on hormone therapy and on the GLP-1s. And it turns out the women who were on the GLP-1s and the hormone therapy combined, overall had better relief of symptoms, more weight stability. And so you're going to see these medications used for a lot of different things. There's emerging data right now on GLP-1s and long-term brain health, right? So we always call dementia, I guess those of us that are really have spent a lot of time and care about educating and learning about dementia in women, we know it's considered diabetes type 3. It's an inflammatory process. It's an oxidative process as well. And so it's kind of been referred to unaffectionately as a diabetes type 3. And so these GLP-1s, we're going to see that drive down the risk because it's driving down comorbidities, right? You're driving down risk of vascular events. Well, that increases your risk for dementia. And so you're going to see more on that as well. I have a hard time finding someone not to use these drugs in. Unless they just don't, unless their lipids are perfect, they're not, their BMI is less than 25. I have seen some internists put patients on these who have high lipids, who can't tolerate a statin, and they may have had a single cardiovascular event in the past. I'll see them put these patients on GLP-1s, and they're not necessarily with a BMI that's elevated. And so you're just going to see them used for a lot of different things. And I hope that's really good. I hope we're going to see a stage shift of people living longer at a lower weight because of these medications.
Yeah. I read something interesting about them too, with the more research being done about anti-inflammatory qualities of them. And so that could even broaden them for prescription purposes in the future.
Right. Maybe that extends to autoimmune diseases. A lot of things in medicine, unfortunately, we work backwards. We're like, well, patients did better on this. Now we need to go figure out why. And so what got you to the party was diabetes. Now you're at the party and it's weight loss. And so we'll see where this goes long term.
Yeah.
Okay.
One more quick question in closing. What if for the men that are watching, listening, what do they need to know to support their women in their lives? As women are moving through perimenopause into menopause. I saw a video this morning on social media that I thought was hilarious. One of my friends sent me, and it's a guy with a towel, and he's trying to figure out how to throw it over the alligator. And it's like husband trying to, balance his wife when she's on perimenopause, and then he throws the towel on him. And they like, oh, it was so funny. So what do men need to know to walk this journey alongside of all of us?
Well, I appreciate whoever the individual that posed that question. I would say, imagine if you woke up tomorrow and you walked off a cliff and you had no testosterone and you didn't want to get out of bed.
Hmm.
You thought everyone was out to get you. Your skin all of a sudden literally changed within months. And you felt just 10 years older than you did the day before, because sometimes for some women, it's just like falling off a cliff. And you didn't want to have sex, and you just didn't want to do anything that brought you joy. And I think that a lot of women don't realize that can be some of the signs of menopause. And I just say, imagine for a moment if that were you. And number two, we didn't ask for this, right? And it is a reminder to us sometimes that we don't want it to be this, and I don't want to leave on this. I hesitate to say this, but this is, there may be some loss of innocence or loss of vitality that can go along with that. And that's what we're all working to prevent and say, hey, this isn't the last act. This is the next season. This is not even the season finale. This is Emily in Paris part 4. And so this is good stuff where everybody's finally going to come. It's all going to come together. And so I think that we just have to recognize that we get to be a little bit like, hey, I wasn't ready for this. I feel like the worst thing you can do is say, well, I mean, you knew this was going to happen, right? Like, no, nobody wants to hear that. Because I think there is a sense of like your loss of vitality, and that you're moving into a different stage of your life. And even me as an OB-GYN who has been working in menopause only for the last 5 years, I say only because there are people who are doing it far longer than me. I didn't think it was going to happen to me. I mean, what? So, and here I am. So it happens to 100% of us women. And so, I think we have to understand that for some of us, it's a pause, hence the word. And we think that maybe we're just trying to regain some vitality in some of our youth and hold on to what makes us feel like ourselves. And we just really want to feel like ourselves.
Thank you, Dr. Kamilia. So where can everyone find you? And two, if someone wanted to book with you, have you be their whole woman, whole wellness, whole person, concierge person, how do they get in contact with you?
So my practice is a private practice. It's Charleston House. It was really designed to kind of fill this gap for women in the healthcare system that didn't belong in the obstetrician's office anymore. It's not just menopausal women. It's all women who've decided not to have children, and each have a unique journey. And just like it's funny, as I've always said, like the woman in front of me drives the care that I need to give. I made a model, and women evolved in front of me, and I had to evolve with it. So I was like, women are evolving. Healthcare should be evolving with them. But I created one sort of like model. And then I was like, so about 6 months ago, I was like, okay, well, I have to eat my words because women. And so I recognized that something needed to happen. So while I have a concierge practice, I've opened up my practice to women who maybe just want to see me once a year, or they just want a menopause consult. And we've got women all over Texas now that are signing up, and we can do it virtually. They get their blood work checked before.
Nice. We
sit down and have an hour-long consult. And then they can go on and hopefully be educated, empowered, and take that information and get on their way and take their prescriptions and go see their practitioner and educate their practitioner along the way. And so we've opened that up to just menopause patients. So you don't have to be a concierge patient at Charleston House anymore.
Oh, perfect. I love that. I love that. Like, so anybody virtual, or maybe you just want to go to Dallas when it's not summer to get on that list. I would say maybe February is always nice, March.
Yes.
To come, but
Nadine, yes. Heard you, Nadine. Yes. What about social media? Where can everyone find you on social media?
Charleston House and at Dr. Kamilia Smith.
Instagram,
and
Facebook.
A little bit.
Again, LinkedIn. Yes.
LinkedIn, yes, ma'am. LinkedIn.
Okay. All right.
Yeah. And on your podcast.
And episode 5, season 1.
Season 1,
so far. Yes. So far.
And on our Facebook, on this, on our live that we just did, this will be on all our social media pages as well.
Yes. Anyone watching, if you've come in late, this is available on demand once we conclude. Facebook, LinkedIn, YouTube, Instagram. Oh God, we're everywhere.
We're everywhere.
TikTok. I keep telling Julia, we got to get on the TikTok.
Because we're all just getting better. We have to be everywhere.
Dance on TikTok. And for anyone just joining us for the first time again, if you have missed season 1, you can catch all of season 1 on demand of Just Getting Better in Apple, Spotify,
YouTube, wherever you get your podcast.
Yes.
You can find us.
YouTube and follow all of our social media channels, and we'll be hitting season 2 in late September.
Yeah.
Thank you, Nadine. Thank you. Yeah.
Thank you, Dr. Kamilia, again.
Yes.
Thank you
Dr.
for having me.
Yeah.
It's always a treat to talk to you.
Always,
and I know as we're getting now feedback and people, yes, they always, our audience enjoys listening to you.
Thank you
you
very
give us
much.
a lot of good guidance. So.
Well, I appreciate you guys having me.